Thank you for introduction. It's my pleasure to be here just to present for you our data from the last analysis we did it in demographic and clinical characteristic treatment outcome of patient of Burkitt lymphoma that treated in Princess Noura Oncology Center since 2000. So Burkitt lymphoma in a brief, as we know all, it's a rare aggressive B-cell lymphoma, and we know that it's actually usually related to MYC rearrangement, and it has a 3 distinguished type. This type actually is differ clinically and geographically distribution. So they had 3 types, the endemic type, sporadic, and immunodeficiency type. It has also 2 incidence peak. It's coming in childhood period, and also it's coming in adult. So you can see like in 30 and 40, we have a median age of 40, but in some trial it extends even up to 47. And it actually have some male predominant. So this is just a graph from SEER database to show you how the incidence of Burkitt lymphoma being increased since 19th. It actually, this is just the data until 2008, but it's actually it's steady or increasing more in 2 gender, male and female. And with this increase, actually, we discovered that also the survival being increased. You can see that SEER's database distributes the patient between 4 groups according to their age. All 4 groups actually improving. Apart from the age more than 60, you can see that the graph is still showing that it's still, they have a lower survival compared to the one younger. So I would just go through some chemotherapy being used in Burkitt lymphoma that may be in the cause of improvement of the survival of Burkitt lymphoma. So starting from MAGRATH protocol since 1996, actually it includes a small number of adult patients. Most of the patient was pediatric group at that time, and they didn't reach their overall survival. It's just event-free survival, but it was good actually, 92. And this protocol actually modified multiple times until they reach a good survival. They reach even more than 70 or 80%. Then come to Raziri to 2004. This also tried to introduce a CAL-GB, which is an ALL protocol, to Burkitt lymphoma. They have a lower survival and event-free survival. That's why, again, they try to modify the protocol 2014, and they have a good survival, actually 78%. Then coming to the other protocol of ALL, which is the Hyper-CVAD, Thomas introduced it since 1999. It had a lower survival. Again, as usual, they try to modify it because of a lot of patients in the elderly group above 40, so they try to modify the protocol according to that, and they have a good survival, reaching 89 at that time for 3 years. Then they even try to put some like a pediatric inspired protocol, which is LMP regimen, and they have a survival of 70%, which is accepted regards. Coming to the new things added to the Burkitt lymphoma, which is the use of less intense chemotherapy, which is not actually being used previously, which is the R-epoch, dose-adjusted R-epoch or short-course R-epoch that's been used in HIV. Don Levy, since 2013, he tried to involve this protocol in the treatment of Burkitt lymphoma, trying to decrease the toxicity also. And actually, he reached a very good overall survival and event-free survival in both group HIV and non-HIV patients. So this is just a graph to summarize this basic table, just to see from the first look, you can just recognize that the Burkitt lymphoma is actually a curable disease, very good overall survival, and very good progressive-free survival. If you use any protocol, you use it. So what about HIV and Burkitt lymphoma? It's not like the other part or other type of lymphoma. Actually, CD4 count or status of HIV didn't change much the incidence of Burkitt lymphoma. So if you have even a higher CD4 count, like more than 200, you're still at risk to have a Burkitt lymphoma. And even with the introduction of a new antiretroviral, still the Burkitt lymphoma is there. It didn't decrease the incidence. So why Burkitt lymphoma? we've been just searching the literature regarding any data in Saudi Arabia, Burkitt lymphoma. Actually, we didn't find any supporting data apart from small data in pediatrics group done, I think, by King Faisal Specialty Hospital in Jeddah. That's why we started to conduct like a study. We thought that it will be helpful, inshallah, in demographic. So we started collecting our patients from flow cytometry, pathology, hematopathology data, all patient diagnosed, confirmed diagnosis since 2000, and chemotherapy software being reviewed, medical record being reviewed, and we keep calling the patient that we missed their data. So we started with a 90 patient identified. Unfortunately, we have to exclude some of them because of missing clinical data, and we end up with 62 patients. About our patient characteristic, we start to actually group our patient age-wise to more than 45 and less than 45. And to let you know, 45 was our median age in this study. So actually they distributed the same between both groups, female gender and male gender, some male predominance, as we say. Most of our patients were in a good, actually, ECOG. The less performance was the small group. And regarding the patient or disease they have, the patient with a multiple comorbidity was a small group, actually 3 patients only. And the one with DM was more like 12 patients, and the other comorbidity in a form of renal impairment, liver impairment, organ transplant, any other we included in the single comorbidity other than DM. P symptoms, most of the patient, and HIV patient, we have only 9 patients included in this study, HIV. So what about the disease characteristic? Most of our patients, like advanced stage, high risk patient, and high LDH, of course, bone marrow in 24 patient from our study, which is represent 38% from the study, and CNS positive was in 13 patients, which represent 21% from our study. So this is just to emphasize that all or most of our patients are advanced stage, high risk, with bone marrow and CNS involvement in a good number of the patients. Coming to the type of chemotherapy we use, actually we categorize our patient to 3 types. Intensive chemotherapy, mainly R-Codex-M and R-Hepasiva being used, and R-Epoch, either dose adjusted or short course for HIV, and less intensive chemotherapy in a form of R-CHOP or RCVP. So we see that most of our patients treated with intensive chemo, 36 patients. So what we find? Actually, we have a good overall survival. You can see in this graph and also in the table that our overall survival were 77.6 in 2 years, and in a 5 year it was 72.1, and the progressive free survival was 60.6 and 53 in 5 years. We start to sub-analyze our patient overall survival and progressive free survival according to the characteristic that we have, starting from the age. So you can see that in our study, we didn't find actually that the age is really significant affecting overall survival and progressive free survival. You can see that the survival for the group above 45 is 67. It looks like it's lower, but it's not statistically significant. And progressive free survival was 65.6 in a 2 year, and 55 in the patient more than 45, but it's still also p-value was 0.5, so it wasn't statistically significant. Coming to the comorbidity effect, with the most prognostic factor we found it in our study, you can see that the 3 patients we talk about, they have a multiple comorbidity. None of them make it actually. All of them died even in the induction period. But the other comorbidity, DM, did well, and the single comorbidity also did well, and none of them was significant. To have one of them or none is equal. Unless you have a multiple comorbidity, nothing will affect your treatment. So just to summarize what I said, overall survival and progressive free survival from our study, it's actually matched the SEERS database, and we have a similar gender distribution. And the age has no impact in our study on the treatment, just to tell you and tell us that the age is not per se a cause to decline patient from treatment. And the presence of diabetes mellitus actually wasn't a problem or prognostication that decreases survival in the patient. It caused some toxicity like hyperglycemia in the patient, but it didn't affect the overall survival. The most prognostic factor was the multiple comorbidity, as I said. It actually, the significant impact and actually lead of death in all patients involved. So this is just a graph, the plot I give it to you from population-based study and the severity of comorbidity, how it's affected non-Hodgkin lymphoma. I just try to tell you how the high impact comorbidity, and I mean by high impact the multiple comorbidity in this study, impact the survival for the patient of non-Hodgkin lymphoma. So it decreased the survival even to reach less than 30% of 30%. So coming to other part, which is the disease characteristic, what is the effect of CNS, bone marrow, and others? We found that the CNS actually affects our progressive-free survival. You can see that the patient with a positive CNS have a progressive-free survival of 43.3. The effect in the overall survival is there also 68.4, but it wasn't statistically significant. You can see that the marginal significance with the progressive-free survival, that means that the patient with the CNS upfront, they are prone to progress or relapse. This is matching the historical data that actually published since 1970, that the patient with the CNS actually presented with the CNS have a very poor outcome, and this is what we found in our data. This is other study actually published in Hematologica regarding the patient with a positive by flow cytometry, the CSF per se. And they said also that the patient with the positive flow cytometry have a very inferior survival than the patient with negative CSF. Just keep in your mind that the CNS positive in our study doesn't mean that CSF positive only, but it's also including the patient positive by imaging. So bone marrow infiltrate, it is another significant result that we found it. Positive bone marrow, we have a 64.2 survival compared with the 85 survival, with a very significant result. And also progressive-free survival is a 47.8 compared to the 68.8 in a patient negative bone marrow. So it's a significant result. And this is match actually also the data from this published in Blood 2009, that the patient with the bone marrow bone marrow positive have an inferior survival. You can see just this row. I just pointed to the red row. And the green one is the one without bone marrow involvement. So what about an HIV effect in our patient? As I said, it's only 9 patients, but still we can say that the patient with HIV have a good survival. HIV per se didn't affect our survival in patient. You can see 2-year survival is 76.2 compared with the 77.9, and the progressive-free survival was 55.6 compared to 61.5. It's actually matching the other data apart from the Levy, which giving like 100 or 90%. And this is the same trial I mentioned, Don Levy in 2013. He used R-Epoch and short course Epoch RR, which is double rituximab, in a patient with HIV. So just to tell you that the patient with HIV have the same outcome like patient with a non-HIV patient. And this is what we have also in our data. So coming to the intensity of chemotherapy, does it affect our outcome? We have with the intense chemo survival of 77.2, with R-Epoch either way, 86.2, and palliative, I wrote it palliative, but I mean a less intensive chemo, 64.8. and the 5-year was 64.8. You can see that none of them were significantly. It's not a statistical significant, but still you can see that it's lower when patient use R-CHOP or RCVP. The progressive-free survival also is lower in a patient. It's actually extremely low in a patient with less intensive chemo, which is the one I'm pointing to in red, 33.3 in 2 years, and in 5 years it's 33.3. Maybe it's not significant because it's a small number of patients, but still you can see that the percentage per se, it's lower than the one with intensive chemotherapy. So just regard the intensive chemotherapy, you have to know that most of the protocol, those intense chemotherapy being published, and they exclude patients with significant comorbidities. They actually ask about patients with good creatinine clearance, liver function, cardiac. So all fit patients were included in our trials, were young patients, and we have a good outcome. Regarding our epoch, actually it's obviate the need of high intensity treatment in our patient of HIV or non-HIV. We have a very good outcome. And actually even in an elderly area, our HIV, like 3 or 5 patients were above 60, and they did well actually. Regarding the less intense chemo in elderly, I just support the word of Dr. Raoul that we have to look to each patient separately. So if you have a patient more than 60, don't treat them all like. Just try to see the significant comorbidities, try to see each patient separately, and you will find those patients that they will benefit from less intensive chemotherapy, and actually they will have a good survival. I think I end. Thank you. And this is just thank you for all staff in hematology and BMT section, and thank you for all lab, hematology, pathology, and flow cytometry, cytometry and medical record that be incorporated with me. And thank you for Dr. Abrar for his actually crucial role in data analysis of this data. And thank you for all patient families included in this study. Thank you for all audience. Thank you.